and we are starting with our first episode of this technical tips from the Titans. Is the first episode in this season, and last 2 years we were enjoying this wonderful series, and nearly 24 episodes were there. They were very nice and very informative. For today's event, we have got a very eminent speaker, Professor Pauli, and he needs no introduction to the hernia people really, and he's a pioneer in many of the procedures in the hernia. He's from United States. He hernia and the bariatric surgery unit and the minimal access surgery he does there, and uh, this is a very difficult and a very interesting subject, parastomal hernia. And as the title goes, there are no easy solutions. Of course, we need to learn from Professor Pauli that what preventive measures we shall take, and to prevent these parastomal hernias. And also, he's going to enlighten us on the management of the parastomal hernias. It is very relevant to say here that he has his own modification of the sugar baker technique for this hernia, parastomal hernias, and we will be all delighted to hear from Professor. Sir, over to you.
Well, thank you very much, Vijay, and thanks to all of the moderators for this evening, Sarfaz, Sumit, Dipraj, and especially thanks to the Hernia Society of India for hosting me. We're going to spend the next, I guess, 35 minutes or so going over some information, and I think we have some time for some questions as well. And so with that, I'll launch into this. And I think the title that you guys have assigned me is really a good title because, I mean, this sums up the whole thing. I mean, there are absolutely no easy solutions to this problem. I do have some disclosures. Those disclosures should have no bearing on what we're going to talk about today. Just make sure my slides are working here. There we go. I do work for some mesh companies, but we're not going to make any specific recommendations about mesh this evening. For those of you who don't know, the first recorded successful colostomy was formed by a French surgeon named Duret, and it was on a child who suffered from imperforate anus. I mean, interestingly enough, that child actually lived to at least 45 years of age. We've had 231 years since that event to try and figure out the way to fix hernias that happen around stomacytes, and we have not yet figured it out yet. Earlier this year at a meeting, Dr. Henneford, who also I think needs no introduction, uttered these now famous words: if you want to make yourself look bad, repair parastomal hernias. And I think that those are really quite true words, and really I think do reflect my experience with repairing parastomal hernias. It's a very humbling field. So for this evening, my goals are to provide an overview of some of the complexities and challenges of managing patients with parastomal hernias. And given that this is intended to be a technical talk, we'll talk about how I repair parastomal hernias utilizing transversus abdominis release, and we'll talk a little bit about poly-peristomal hernia repair. And I think importantly, I think talking about some of the evolution of peristomal repairs over the course of time, I think is helpful to give people insight about how we got to where we are and why we do some of the things that we do. So let's set the stage and define the problem here. Peristomal hernias are very common. Some studies suggest up to 50% of all stomas will have a ostomy site hernia. It's probably higher than that if you look at autopsy series on patients who have peristomals, who have stomacytes. We know that they are more technically challenging to repair, and when you compare them to a standard ventral hernia, we know they have a higher recurrence rate. We know that they have a higher surgical site occurrence rate as well. And then you have to add on to the top of the repair the morbidity related to the stoma. These are non-clean wounds. You can accidentally injure the stoma directly or injure its blood supply. In this picture here, we've got a patient who accidentally had a transfascial stitch that nicked the corner of the bowel, and we have an active mesh infection and a fistula. I think unique to this is the fact that many of these patients have a midline hernia in conjunction with the peristomal hernia. Now, I will say that that's changing a little bit in an era of laparoscopic and robotic surgery, where some operations are performed such that there's only one major incision in the abdominal wall to deliver a specimen and then form a stoma. But many of the people that I meet still have a midline hernia in association with their stoma. Are these challenging to fix? They sure are. This is a recent paper from the group of Michigan that looked at Medicare claims for patients undergoing elective parastomal hernia repair. And this was an older patient population because that's who uses Medicare in the United States. At 30 days, they had a 3.8% rate of death, a 40% rate of complications, and a 10% rate of readmission. And when they adjusted, the 5-year incidence of reoperation was 21%. And so these are clearly a very morbid set of operations to do. And that's only magnified when you do it on an older population, which is why a lot of us practice non-operative management for select patients. So this is a great paper from colorectal disease a couple years ago, where they did a multi-center review of patients with parastomal hernias, and about half got surgery and about half were managed non-operatively. For those who were managed non-operatively, the reasons for doing that were patients didn't have symptoms, the patients preferred non-operative management, the patients had too many comorbid conditions to get surgery. But interestingly enough, the most common reason for people to not get surgery was not actually listed in the medical chart when they evaluated. So maybe some combination of surgeon preference or surgeon inability to do the repair that was necessary. Now, if you look at these rings, the outer circle represents the non-operative management and the inner circle represents the management patients. And the biggest reason for patients to be managed surgically is that red portion of the circle, which is pain, which occurred in 57% of patients who got surgery, but only in 16% of patients who didn't get surgery. So when patients have pain, that's probably the main reason why we are operating on them. The second most common reason, which is a very legitimate reason, is appliance leakage, which, if you notice, was only 14% of the people who got surgery, but was 24% of people who did not get surgery. And again, I think that emphasizes the need for patients to have access to a good stoma therapy team, because if you can take 24% of people who are actively having leakage and manage them without surgery, you're probably doing something good by the patients by avoiding those surgical interventions. In the surgery group, in the non-surgery group, 21% of patients ultimately got a surgery. So people are crossing over into the operative arm of this sort of retrospective study, but only one of them needed an emergency operation. So when people cross over, it appears that they do cross over safely. In the surgery group, more than half of the patients recurred. And of those that recurred, the vast majority required another surgery. So seemingly, when you open up this can of worms, it's hard to get them back in the can again, and you may need to be prepared to do reoperations in the future. So our history of operating on surgeons, operating on these, seems to go back to around 1965. If you go through the surgical literature on this, you wind up way back with references to this book chapter from Thorlaxon, where he advocated a direct approach to the hernia, where you make some form of incision around the hernia. You could also take down the parastomal hernia directly at the junction, but you identify the hernia sac and remove it. You close the fascia with sutures, and then you close the defect. And I will also say that this repair is not dissimilar to a local repair that any of us might do today. But again, the first reports of this in the 1960s. What we know about suture-based repairs like that operation is that they have a very high recurrence rate. Up to 75% of them will recur. And if it is a recurrent hernia, meaning if they've already had one repair, 100% of them will recur if you're only doing a suture-based repair. And that's roughly 9-fold higher than a mesh-based repair. But there are some really good parts about doing a local suture-based repair. It's technically simple. It avoids relocation. It avoids morbidity related to mesh. It avoids going into the abdominal cavity in a very real extent in many patients. It's got a low morbidity, all things considered, and it can be done locally. Now, and I certainly do this repair mostly in people who are too sick for any other surgeries. This is also my go-to emergency repair option for people who have not been medically optimized. The one thing that I will say is that when I do these nowadays, I don't do them with suture. I do them with mesh suture. And we have access to commercially available mesh suture products. And what that repair looks like, again, is an incision around the stoma site. I usually try to stay outside where the patient wears their faceplate, although it's not always possible to do that. You take down the sac, you reduce the content, you close the fascia, and I think that mesh suture, for a variety of reasons, is a great way to close fascia. And when we know people have a very high rate of recurrence, as in this group, I think this offers some advantages, although there's not a lot of data to support that. That's just personal opinion. So why do we like mesh-based repairs? Well, again, I think that this study helps us get some understanding of why mesh-based repairs are helpful. It's 51 patients undergoing repairs, and it's split about 1/3 primary repair, 1/3 local mesh-based repair, 1/3 relocate and repair the stoma site with mesh. 40% overall recurrence, highest in the primary group, middle in the local mesh-based repair. But when you move the stoma to a new site and repair with mesh, you're getting a 24% recurrence rate. But you have to understand that what they're calling a recurrence is not a hernia where the initial hernia was. It's a new hernia at the new stoma site. And this is the issue with moving stomas, is that while you can more easily fix the old parastomal hernia site, because now it's just a ventral hernia, you are causing new defects in the fascia and are going to begin to develop hernias at those new locations. For the next few slides, we're going to be talking about mesh and mesh configuration. And so I want to make sure that we are all on the same page about the terms that I'm going to be using. When I say a keyhole repair, what I'm describing is a method where you generally leave the stoma in situ, where you cut the mesh and wrap it around the stoma, and then you sew the edges of the mesh back together, and that's a necessary and sort of mandatory step for any keyhole repair. That can be done in any of the abdominal compartments. That could be an underlay, an onlay, or a sublay operation. When we talk about a cruciate, what I'm describing is a repair where the majority of the mesh is left intact, but an X or a defect is cut into the mesh to deliver the bowel through the middle. Again, this generally means the stoma has been taken down and you are delivering it through a piece of mesh. And again, that can be done in the underlay, onlay, or sublay spaces. When we talk about a sugar baker configuration mesh, and we're using that word to describe not an operation per se, but actually just a mesh configuration. That generally means the mesh has no cuts in it. And as you can see in this image, we are swinging the bowel around the edge of the mesh to create a tunnel within the mesh. And while we generally think of that as an intra-abdominal operation, we're going to show you sort of our modification of that to be a retromuscular operation or a sublay operation. The one thing that I will say is that this operation obviously cannot be done in the onlay space because you don't want the bowel kinked above the level of the fascia. There are within those mesh configurations, obviously, there are a lot of different ways to do it. And we're not going to talk about algorithms for doing this today. I do just want to point out there's lots of different ways to think about, how and when you want to do each of these. There are a lot of other configurations that we're not going to address today that include, sort of dual layer repairs like this keyhole and then a sugar baker. In Europe, I'm not sure about India, but perhaps there are funnel configuration meshes that are also commercially available to allow you to have mesh that basically wraps around the bowel without needing it to be kinked or bent around the edges. So where did the idea for mesh-based repairs come from? Well, about 10 years after that Thorlaxon paper in 1965, Rosen and Bernardi published a paper outlining 7 patients who had prior APRs. This paper is actually really great to read for a variety of reasons. Number one is this figure is described as the grotesque appearance of a paracolostomy hernia. I mean, this This, in my practice anyway, is a pretty standard parastomal hernia nowadays. This is not anything exciting. What they did, though, was take down the stoma by taking not only, they didn't disconnect the mucocutaneous junction, they took a very large skin paddle and fat along with it in an attempt to sort of reduce the dead space around the stoma. They closed the peritoneum as a separate layer. They closed the fascia with some sort of permanent suture. They excised the excess colon. And then they took a piece of polyethylene mesh, which at the time went under the brand name Marlex. So while it says in the paper it's Marlex, it's actually polyethylene. They secured that to the fascia as an onlay repair. You can see they've created a defect in the mesh to deliver the bowel, and they put everything back together. This paper is also interesting because if you read it, they were so satisfied with their results that they actually suggested that you should do this every time you form a stoma to prevent a hernia from forming. So in the very first literature on mesh placement to fix a hernia, those authors are suggesting that we should do this for prophylaxis as well. Now, I think a lot of us are familiar with the name Sugar Baker for a variety of reasons, but his name is mostly associated with parastomal repairs. I do want to point out that the thing that you think Sugar Baker described is not really true. Sugar Baker's primary concern with that Rosen and Bernardi paper was that he did not like the idea of working directly through the contaminated field and mobilizing and doing a lot of work with bowel. And so what he did was basically exclude the colon from the field with a plastic drape. He then went intra-abdominal by utilizing a midline or an old paramedia incision, whatever had been used to give the patient their stoma the first time around. He left the hernia sac in situ, and he cut the mesh so that it basically snugly fit the fascial defect. So this is an inlay repair, okay? There's no attempt at overlap at all. You can see in this drawing that he sutured the colon to the lateral abdominal sidewall. And then really what he's done is he's left a gap in the abdominal wall where the mesh meets the fascia at the edge of the defect to allow the bowel to enter, all right? So there's no attempt at mesh overlap. There is not really a tunnel of mesh wrapping around the bowel. There's just overlap within the fascial defect itself, okay? But this has a lot of advantages. The stoma is left in situ. You're not operating through a field. The mesh is intra-abdominal. It's not in the onlay space. So there's a lot of good things. I will point out that again, at the time, this is a completely uncoated piece of mesh being put inside the peritoneal cavity. And this is uncoated mesh directly against the bowel. All right. All right. Voigt gets credit for sort of a modification of Sugar Baker's technique to give you a repair that looks much more like what we think a Sugar Baker repair is today. This is a laparoscopic operation done with a surgeon and assist. They're using polypropylene mesh. It was just Ethicon Prolene mesh. Again, it's uncoated mesh in 2000. But what you can see here are a few things that we would look at as a more modern hernia repair. Wide mesh overlap of the defect. Multiple areas of mesh fixation with permanent screws. And then what you're seeing is this concept of creating a tunnel. They did that because they wanted overlap of the mesh from the defect. And the only way to do that is to have a tunnel of bowel running through mesh. If you read the paper on this, what they are comparing this to is the way that we do an intra-abdominal inguinal hernia repair, okay? If I showed you this figure, and instead of saying colon in the figure, if I told you that that was the spermatic cord or the round ligament, and that the hernia defect was an indirect hernia defect, you would say, yeah, I get it. This is exactly how I do a TAPP inguinal, okay? So it's a modification of an IPOM that is much more similar to a preperitoneal inguinal repair, particularly a STOPA type repair. They said that many surgeons have an aversion to allowing bowel and mesh to touch, while it might be tempting to have a flap to cover the mesh, they're saying that it's too difficult to harvest intact peritoneum to cover. And so what they are saying is, we get it. We don't like to have permanent mesh uncoated mesh infraperitoneal, but it's really challenging to do that laparoscopically. Now, I will say there are some things in this paper that I don't like. For example, they said there seems to be no learning curve. I want to point out that the history of surgery is the history of surgeons saying everything I do is simple. There are no complications with this. It's easy and anybody can learn how to do it. I will say that that this paper is fraught with that problem as well. They do say the study lacks numbers and operations and follow-up to say that it's definitively useful, but I think we know that this repair became for many years the go-to laparoscopic way to fix this hernia. I want to take a brief step back from the year 2000 in that paper to 1993 and focus on this paper by Alexander and Billiot, who created a retromuscular pocket in order to repair parastomal hernias. So this is an open takedown of a stoma. And here they're showing a stoma site. You can see the little repair site there where they've taken down the stoma that was through the semilunar line or maybe lateral to the semilunar line. And they have moved it to the middle direct center of the left rectus abdominis. In order to do this, they've created a retromuscular pocket. And they made that pocket not only retrorectus, but to get lateral to the semilunar line, they went between the transversus and the internal oblique. And we all understand that that's a bad way to fix a hernia because it divides the neurovascular bundles that enter the semilunar line, okay? Many of us learned that operation as what we would call a Carbonell-style posterior component separation. And while it has some things about it that make it nice, like it's relatively straightforward to do and the mesh is between two layers of muscle, we know that it is deconstructive to the abdominal wall in a way that is permanently debilitating. That being said, they were able to make a nice retromuscular pocket. They placed a 20 by 20 piece of Dacron mesh. They reinforced the old parastomal hernia, which they converted into an incisional hernia by taking the stoma down. They've created a defect in the mesh to deliver the bowel through, so they now have a mesh that is reinforced from the very beginning, and they've done it with either a paramedian or a midline incision. Now, I'll also point out that in this paper, they said, if you feel like you need to move the mesh to the other side, contralateral to where you're working, you can just make a retrorectus pocket on the other side. And I think if I showed any of you this drawing and said, does this look like a modern parastomal hernia that you might do open? I think the answer is yes, okay? I learned a modification of this version as sort of what I'm going to call and refer to as the classic open retromuscular parastomal hernia repair. These are some figures from early in my career fixing parastomal hernias, and this is similar to the repair style of parastomal hernias that Dr. Rosen and Nowitzki taught me back when I was a fellow more than a decade ago. That involves a takedown of the stoma. It involves a retrorectus dissection. And when you do that, you're obviously going to have a defect in the posterior sheath where the old stoma used to be. When the hernia is large, that defect might be big. When you're doing this more for a large midline hernia with a smaller parastomal component, it may be a small defect in the posterior sheath. It then involves a standard transversus abdominis release. Again, sometimes that can be a challenge because if the hernia goes through the semilunar line, you now have to understand how to do a TAR when there's a big defect already in the middle of the semilunar line, which is in the vicinity of where you're doing that release. It involves some amount of contralateral dissection, and that might be retrorectus alone. In most patients, it was a bilateral transversus abdominis release. You have to close the hole where the old stoma was located. You have to close the midline. You have to create a defect in the posterior sheath somewhere under the contralateral rectus abdominis to form a new stoma and deliver bowel through. We would then put a large piece of mesh in the retromuscular space and create a cruciate defect to deliver the bowel through. You then create a trephine through the skin, anterior fascia, and rectus muscle and deliver the bowel to become a new stoma site. This is what the repair looks like in an AP view, and there are some good things about this. The old stoma has been converted to an incisional hernia. It's got wide overlap. You're not going to get a hernia back at that location. Your midline hernias have overlap in most directions pretty widely. Unlikely you're going to get a hernia back. But there are some problems with this. And I think that this cross-section view highlights some of those problems. Again, when you look at this, it looks great, but I want to point out, and I want to ask you to all think about what happens when you've anchored the mesh laterally with sutures and you haven't closed the midline fascia yet. Well, when I close the midline fascia, you can imagine that that stoma, which goes directly through the mesh, is going to kink in a little bit of a fashion, okay? You've created a defect in the middle of that stoma site. And when you create a defect in the middle of the stoma site, right here, here's a defect. Number one, we know that this is a natural area of weakness. Number two, all of these layers are independent. The posterior sheath, the mesh, and the fascia layers are independent. And when you pull these back together in the middle, you do get some element of scissoring and kinking in the retromuscular space, which is part of what makes this operation challenging to perform unless you've learned it from someone who's good and done a bunch of them. Now, Yuri Novitsky and Arnab Manjumder and their group published some ways to prevent that scissoring. A Storm Parastomal repair utilizes an EEA stapler that is passed through the abdominal wall and through the mesh, and it intentionally staples the mesh to the fascia. Why is that important? Well, that means when you go to close the fascia in the midline, the mesh is less likely to kink in that retromuscular space. It basically reaffixes those two layers of the reconstruction together to prevent scissoring and erosion of the mesh into the bowel. Okay, there are challenges that come along with this operation, but that's what a Storm was initially intended to do. So when you do the classic version of a TAR parastomal repair, what do you get? Well, this is Rosen and Novitsky's initial publications on the topic. It has relatively limited follow-up of around 13 months. They had an 11% recurrence rate. It's got some good things. By relocating the stoma, that old stoma site is not going to develop a hernia. The stoma, the new stoma site, is reinforced from the very beginning. This is primary mesh prophylaxis of a stoma site. It definitely lets you fix midline hernias if they occur with the stoma. But the downside is you're moving the stoma. So there's a lot of bowel mobilization. You've got to have good mesenteric length to reach the other side, and that's not always true. You have multiple different wound sites to deal with. And I think most importantly, and I've mentioned this before, the mesh is cut. In my experience with doing this when I got out into independent practice was that most hernias were occurring at that new stoma site. I will point out that you will have ischemia of the stoma. You're going to have some issues with mucocutaneous junction when you're reforming it. And so this operation is not without issues. I think the main reason we initially liked doing this was the understanding that mesh reinforcement of stomas reduces the risk of getting a hernia back, or so we thought. I think what we're finding out now with new meta-analysis on primary mesh prophylaxis is that prophylactic mesh does not prevent parastomal hernia recurrences. What it does is delay the time to which those recurrences become clinically relevant. Okay, so the literature on mesh prophylaxis is beginning to shift a little bit. That was my experience, and that's where poly-peristomal hernia came from. And again, I don't want people to think that I necessarily set out to design something different. This was really a complete accident. I was teaching a parastomal hernia course at the University of Pennsylvania. We were teaching parastomal hernia repairs. Someone wanted to learn how to do a TAR on the cadavers that we were working on. And it just, in that moment, and while I was in the middle of dealing with a number of complications from some complex parastomal hernia patients, a light bulb sort of went off. And this is really nothing more than a combination of a classic Yuri Novitsky a TAR operation with a sugar baker configuration mesh. And while it does combine a lot of the good things of both of those operations, it obviously has all of the bad things that come along with both of those as well. And again, for those people who are not actively doing parastomal repairs, I'm going to emphasize repeatedly throughout this talk that this operation is challenging to perform and configure correctly. I'm going to show you some figures which are cadaver dissections, mostly because it's much easier to show you these things in a cadaver. Also, this cadaver just had particularly awesome anatomy to show a lot of this stuff. So we've done a midline laparotomy, we freed up the adhesions and all the other things you have to do an open retromuscular hernia repair. You can see that we've done the retrorectus dissection here, leaving the stoma in situ. You then have to do a TAR, not only not damaging the neurovascular bundles, as you see here, we're doing that medial to the neurovascular bundles, but you also have to do it above, below, and ultimately around the stoma without damaging the stoma, and that is easier said than done. But once you get lateral, you create a very large retromuscular pocket, as we would for any transversus abdominis release, again, leaving the stoma in situ. And then what we're going to do is intentionally lateralize this bowel. You can see that as we've done the TAR, the area where the bowel enters the retromuscular plane has moved medial, the same way the posterior sheath moves medial. Well, we want to move this entrance site from here way out lateral. And how do we do that? Well, you have to do the thing that we tell you not to do when you do a TAR, which is to intentionally create a large defect in the posterior sheath. We've cut the defect lateral, and we are now going to move the stoma from its entrance site here to somewhere way out here. And once we get it out there, we're going to start sewing this closed from lateral to medial until it is all the way closed, just like that. Okay, so we've transposed the bowel entrance site in the retromuscular plane. And you can understand that if we put mesh in this pocket now, we have an uncut sheet of mesh that is going to cover all of this bowel going from lateral to medial in a very clear fashion. Like any other TAR-based operation, if you're doing it open, you need a landing zone on the contralateral side. So here we've done a contralateral retrorectus dissection only, no transversus abdominis release. And then this pocket gets filled essentially with a large piece of permanent synthetic mesh. I typically use permanent synthetic mesh. What I will say is your mesh choice is up to you, and I'm not going to make any specific mesh recommendations today, but I will show you what the literature says about mesh choice for this operation. This is what the operation looks like in cross-section. I want to show you a few things. This is, again, from a very early atlas on how to do this. You can see there are transfascial sutures in place here. We eliminated our transfascial sutures, and I'll explain why that's important in a few minutes. But again, the nice part about this operation is where the hernia was, right here at the stoma site, we've got wide mesh overlap. Where any midline hernias are, we also have wide mesh overlap without any cuts in the mesh. This is what it looks like in an AP view. And again, this is the original way that we did it, with transfascials around and two transfascials on either side of the bowel, just like in a laparoscopic intraperitoneal sugar baker configuration mesh. Okay, that was our predicate in our mind. That's how you do a sugar baker operation, is with two transfascials. The Cleveland Clinic group published the first series on this, 38 patients, most of whom had a midline component, 11% recurrence rate at 13 months, but with some problems. What were those problems? Mesh erosion. One patient on day 8 had a small bowel perforation. One patient on day 12 had a colon perforation. What does that mean? Well, what that means is that they were trying to lateralize the bowel, and that in their attempts to do that, either the lateralization or the tightness of those sutures led to immediate and early erosions and perforation into the bowel. This is the learning curve of expert surgeons learning a new operation, okay? It was steep even for them. They had an additional patient come back at 4 months with an ischemic stoma, and this is that very patient. That patient's mesh eroded into their mesentery and led to ischemia. That very same patient was a Crohn's patient with a shortened mesentery who is obese, who had an left-sided end ileostomy, so hard to make the mesentery reach. And that same patient also had obstructive issues very early in their postoperative course. And so this patient was probably one of those patients within the learning curve of how to get this operation configured correctly, okay? But what this made me think of, and what we were already starting to do at the time, was to eliminate transfascial sutures. We had already eliminated them from the majority of our other retromuscular operations, and I typically do a TAR with just some fibrin sealant. Because the mesh is retromuscular, it's the peritoneum that keeps the bowel from getting up above the mesh, okay? You don't need transfascial sutures to do that here. In a sugar baker done intraperitoneally, especially if you're doing it with Gore-Tex mesh, which is how many of us learned how to do it, you need permanent fixation there to keep the bowel against the abdominal wall. You don't need that here. We were only putting them because in our mind, the predicate operation for this was something done laparoscopically with the mesh that does not incorporate into the abdominal wall very well. And so we eliminated those sutures. Now, when you eliminate the sutures, you can do some additional really fun things. When you are trying to lateralize straight lateral and you are putting sutures through the abdominal wall, you need to put those sutures where the bowel enters the tunnel of mesh. And that means they have to go through soft tissue. They can't go through bone. They can't go out near other critical structures. And that limits to a great degree where you can make the bowel go lateral. Well, what happens when you don't use lateralizing sutures? Well, an endoleostomy doesn't really want to go lateral. It wants to go inferior lateral along the direction of the mesentery. A urostomy really wants to go directly towards the myopectoneal orifice, directly over the iliacs where its blood supply and ureters are plugging in. Colostomies really like to go toward the left upper quadrant. And so lateral doesn't mean lateral. It means inferior lateral or superior lateral. Now, we've also changed the way we configure the mesh. By getting rid of those transfascial sutures that go out at the edge of the mesh, you can do some interesting things. When you stop the mesh right at the edge of the bowel, you are skimping on mesh overlap in the retromuscular plane. What if you had an old stoma site here that had a hernia and you wanted to cover it with mesh? Well, if your mesh stops here at the edge of the bowel, you're cheating on the overlap. What if the patient has an inguinal hernia? Well, if the mesh stops here, you're not getting adequate overlap. And so by getting rid of those sutures at the location where the bowel enters the retromuscular plane, you now can get overlap of those. And this is how I currently do it. This is a stoma that has already been lateralized in the retromuscular plane. This is our mesh that's about to go in. And what I'm doing is simply bumping the mesh up against the edge of the bowel where it enters the retromuscular plane. And I'm going to ask my resident here to cut the mesh along the directionality that will become lateral overlap up to the edge of the stoma. And I'm probably saying something like, please don't cut the stoma. Please don't cut my fingers. This mesh is going to have a keyhole configuration where the bowel enters the retromuscular plane. We simply wrap it around. And the bowel has a sugar baker configuration where it's sitting in the retromuscular plane. And I'm showing you, when we bring that to the midline, the amount of sugar baker mesh overlap that we are about to get. Okay, that's how I do it. Let's take a brief branch point here and talk about mesh choice. This is a study of patients undergoing retromuscular parastomal repairs, half of whom got biologic mesh, half of whom got permanent synthetic mesh. With 2-year follow-up, there were no differences in infection rates or reoperation rates. There were some differences in erosion. 2 of those patients had erosions that were biologic mesh, 2 were permanent synthetic mesh. All of them were in that cruciate configuration, the classic version of a repair that I learned how to do. None in a sugar baker configuration. When this study looked at recurrences, although it was not powered to look for recurrences, the retromuscular sugar baker or a poly-peristomal had a 10% recurrence rate. The cruciate had a 30% recurrence rate. And this accurately reflects my experience with doing these operations. Now, some of you may have seen that earlier this week, the Cleveland Clinic Group published a randomized controlled trial of sugar baker versus keyhole for peristomal repairs. They randomized 150 patients and said that at 2 years, there were no differences between these configurations. I'm not going to get into the study in great detail, but I want to say a few things. Number one, it's very challenging to randomize patients to one type of peristomal repair. Not every patient is a good candidate for one or the other of these surgeries. Number two, as they were randomizing patients in this study, 20 patients were immediately excluded because the surgeon had a preference or discretion about a kind of repair that they felt was better for the patients. So there's a little bit of cherry picking going on here. In the follow-up, they only had 50 patients follow up in the keyhole group. So they've lost a third of their patients to follow up. And when they compared the groups, there was a 7% recurrence rate in the poly-peristomal configuration, and there was a 26% recurrence rate in the keyhole configuration, with a lot of patients lost to follow-up. And those numbers did not reach statistical significance. I promise you I'm going to keep doing a retromuscular sugar baker operation, because while 7% and 26% might not be statistically significant, for me, they are clinically relevant differences in numbers, okay? We are in the process of actually going through our patients. I've got people who are almost 10 years out from this operation, and that'll be coming to a podium near you soon. For those of you who have access and do robots, there's lots of publications. There's not a lot in the literature, but there is more coming out every day. Jan Lambrecht is doing a lot in terms of this robotically. Vedra has been doing a lot of these, not only as an intraperitoneal repair, but also some preperitoneal versions of the operation as well. You can do this as a single dock or a bilateral dock robotic operation. It's very challenging to do. I'm going to have to restart here. Give me just 1 second, guys. It looks like my program wants to end. So give me 1 second, and I'm going to restart this. I will say that for those of you who do robotic repairs, this is potentially the most challenging way to fix a peristomal hernia. And some of the reasons it's challenging is that you have to do this not only as a single dock, but potentially a double dock operation. You have to be very comfortable robotically operating around the stoma site itself. It oftentimes requires an assistant port to be able to move the stoma out of the way so that you do not injure it, okay? But you can do it isolated as a lap or a robotic operation. I'm going to very quickly go through a robotic version of this, although I do think we're running short on time here. I want to save some time for some questions. Let's just skip ahead in the interest of time. This is some new data from Jan Lambrecht. It's 53 patients with peristomal hernias. Most of them are colostomies. Most of them had a midline hernia. At 24 months, he is reporting a 3.8% recurrence rate, and both of those patients were ileostomies, which again have a more foreshortened mesentery. No talk on this topic is complete without a talk about complications. While the surgery might be a bit more novel, the complications are not. This patient I did a open poly-peristomal on, and he fractured his mesh. And while the bowel is still sugar bakered in a tunnel laterally, his end colostomy looks fine. He's got bowel stuck in the retromuscular tunnel. This patient had an ETEP version of the surgery done in an outside facility, and as you can see, had a fistula there to the midline. Watch here, the bowel is tunneled here well, but broken. This patient has a fistula to the midline. You know, some of these problems have been reported before. Lars Jorgensen reported on mesh fracture in IPOM sugar baker repairs with reduced weight mesh. The bowel is still lateralized, but the mesh is fractured. You can fix some of these robotically. This is a patient who had that fractured mesh, and I had to go back robotically and actually repair this robotically. When you go back in robotically to repair this, you're essentially fixing this as an IPOM repair. You don't need to re-sugar baker the bowel. You reduce the content. And in this particular case, I just did an IPOM repair utilizing a permanent synthetic mesh in the intraperitoneal space. One last thing I want to mention, which is some data from our colleagues in the Danish hernia registry. They looked at what happened when they centralized repairs. Over a 7-year period, they centralized peristomal repairs to 5 centers. And when they did that for elective repairs, what they found was no difference in outcomes, reoperation rates, morbidity, recurrence rates. And you might say, boy, centralization doesn't matter, but more patients got surgery, and those patients had more comorbidities. So in expert hands, more operations were being done on sicker patients. Those are the patients who in that watch and wait series we're probably told you're not a candidate for surgery. Well, when you send them to an expert center, they're more likely to get surgery. And I think importantly, for people who need an emergency surgery, there was a reduction in the reoperation rate from 45% to 23%, and a reduction in the overall mortality from 10% down to 2%. So I'm going to conclude so we have some time to ask questions here by saying parastomal repairs have clearly evolved and continue to evolve over the course of time. We still don't have a lot of information about what the best way to do these repairs are. A poly-peristomal hernia repair can address older problems of operations, but there are a lot of challenges that come along with this. Emerging data suggests a low recurrence rate, but exactly who should get this operation and who should be doing this operation, I don't think we know. All versions, open, lap, robot, are challenging. And again, I want to emphasize, I would not recommend that any of you, haul off and do this if you are not comfortable with a variety of different ways to fix and address parastomal hernias. Delighted to have had the opportunity to chat with you. If you have questions that I can certainly answer them now. If you have additional questions, you can always reach out to me and I'm happy to answer them. Thank you so much for the opportunity to present.
Thank you, Professor Eric. It was a wonderful presentation. It is always pleasure to listen to you. I heard many of your presentations so far. The messages are very clear. The understanding of the subject is very crystal clear. There are certain few questions from the people. Along with me, we have got Dr. Deepraj Bhandarkar, Sumit Shah, and Sarfaraj Beg. There is some issue with the audio of the Deepraj Bhandarkar. Sumit, are you okay with your audio now? Sumit?
Sorry, my audio is not clear.
Okay.
Switch the device, but my audio
I would like to ask one question.
Sumit, your audio is not clear. I'm not sure if my audio is clear either.
One question I would like to ask.
Is my
what
audio
is your
clear now?
technical tip for the patients with the Crohn's disease? Particularly, as you said, that the mesentery is really short. We cannot bring out the stoma as we desire. And moreover, these patients are also immune compromised. Many of them are on steroids or the immunomodulating drugs. And perhaps they might face more complications perioperatively. So how do you manage these cases? And second thing is that do you really do all the cases preoperatively a mesh before you create a stoma?
Yeah, so Crohn's is a very difficult question because number one, there are certainly technical challenges that come along with it. A foreshortened mesentery, a multiply reoperated abdomen. I think you also have to add to that list, is this patient going to need another surgery in their lifetime? And if I cover them in a huge piece of mesh, how does that affect their ability to safely get another surgery in the future? Okay. Those are all things that we discuss with patients. In terms of the foreshortened mesentery, that's probably the easiest one to answer because if the mesentery will not allow a lateralization, then you can't lateralize it. And you are either left with doing a different version of a mesh configuration. You either keyhole the mesh and wrap it around the stoma, or you take down the stoma and move it to another location. Okay. And so again, you can't just go to the operating room with one plan for repair in mind. You have to have a plan A, a plan B, and sometimes a plan C. In terms of mesh and bowel interaction, obviously patients with Crohn's do not necessarily have normal bowel. For patients who have had perineal Crohn's or colonic Crohn's, who are and have been stable for many years, again, it's a little bit of an easier decision to make to talk about putting mesh near the bowel. If I meet somebody who has active Crohn's disease, who has ongoing fistulas, who is getting reoperations, who is not well controlled on their medications, that is not somebody who I would offer a planned permanent repair to because you can anticipate that they're going to have a much higher rate of problems and they may need more surgeries. And so most of the people who I'm meeting are in relatively good shape with their Crohn's. They have not had a problem for many years. They are stable on their regimen. The last thing I'll say about Crohn's is that immunomodulatory medications have really made these patients better surgical candidates, not only because their disease is stable, but because they have targeted immunosuppression. It's very different than, again, even 2 decades ago when I was training and these folks were on broad spectrum steroids and immunomodulation medication, which made them terrible candidates for any surgery and increased their rate of wound complications. Someone being on a little bit of Remicade, to me, it no longer bothers me in terms of my ability to talk with them about a repair. It's really those patients who are uncontrolled and who are getting repeat surgeries that, in my mind, should not be getting really any of the complex versions of a surgery that I just showed you. Can you repeat your other question about mesh? Was it just which mesh do I use in Crohn's patients?
Yeah.
Yeah, again, because of those long discussions that we have, I am still more inclined to offer people a repair with a permanent synthetic mesh, which at my facility is a reduced weight macroporous mesh. But we have a long discussion about the fact that there is going to be mesh and bowel interaction, and they are going to form adhesions at that location, okay? But I think if you look at the history of peristomal repairs, you see that a lot of repairs have been done with that concept in mind, okay? The area that I think most of us see erosions, when we see erosions, in a peristomal repair, but in any other version of an operation as well, is where there's mesh and bowel interacting like this, where there is an edge of mesh. And so if you lateralize it too much, in any form of a sugar baker, this edge is going to erode. When you see mesh folded intraperitoneal and bowel against it, this is where it erodes. It's not flat mesh against flat bowel where you find erosions and fistulas. It's almost always a corner or a fold of mesh that is the problem.
And do you always put a prophylactic mesh in Crohn's particularly to avoid the future stomal hernias?
Yeah, so I can plead the fifth on this one. If I am the person forming your stoma, you and I are both having a very, very bad day, okay? I do not do colorectal surgery. I really don't give people stomas. I don't do a lot of emergency general surgery anymore either. And so the answer is I don't. And if you ask me if I would, 5 years ago, I would have said absolutely, because the literature suggested it was the right thing to do. Nowadays, I think the answer is it probably just delays the time to a recurrence. The other corollary question that I get is, okay, well, if sugar baker configuration mesh is good and prophylactic mesh only delays the time to developing it, should we be studying prophylactic sugar baker configuration mesh when we form stomas? And the answer is we probably should be studying it, but I don't know of anybody who actively is.
Thank you, sir. Sarfaraj, do you want to ask anything?
Yeah, so first of all, thank you, Eric. I want to first find out whether my voice is audible or not.
We got you.
Thank you. So, Eric, I'm going to keep these questions a little simple. First of all, when do we really need to repair the parastomal hernia? That's the first question that I'm sure the general surgeons watching this show would like to know, the absolute indication. Number two, very simply put, there are definitely advantages of open retromuscular repair, but laparoscopic sugar baker is a simple repair. Which case would you take for laparoscopic sugar baker? Which one you will take for open retromuscular? So I'll just first confine myself to these two questions before we delve in a little deeper on this subject. Eric,
yeah, so I think that my initial slide that sort of showed in that retrospective study who was getting surgery and who wasn't, that's pretty close to my sort of thoughts on this. When people come with a peristomal hernia that is not painful, that is not causing bowel symptoms, that has an appliance that fits well, those are people who we observe over the course of time. And I have a number of people in my practice either who have a primary hernia that's never been repaired that we're following, or who have a recurrent hernia after I fix them in some way or another, that are totally stable. I actually just saw a patient who I fixed in 2014 with a cruciate configuration. And for the past decade, he's had a tiny parastomal hernia there. He's totally happy. It doesn't bother him or affect his quality of life. And so I just see him every year for a decade and we say hi, and he's a great guy, okay? And so it really does need to be a hernia that is symptomatic. Many people come thinking that they must have it fixed because someone has put the fear of God in them that if it is not fixed, they are gonna obstruct. And so a little bit of patient re-education that we don't just operate because it's there, because of the challenges. Many people say, got it. I'm willing to live with a little bit of discomfort if it means I can avoid a complex surgery. In terms of who gets a lap or a robotic sugar baker, I think an eye palm repair is great for people who have an isolated parastomal hernia, for sure. And for people who have an isolated parastomal hernia, who have a parastomal hernia in association with relatively small midline components, okay? And increasingly more people, I think, are candidates for that. Again, in an era in which many people are getting their stoma done minimally invasively, okay? I got a laparoscopic total abdominal colectomy for my Crohn's with an endoleostomy, all right? There's one extraction site, it's the stoma site. It's a permanent stoma. They have a couple laparoscopic poke holes other places, and their only hernia is at the stoma site. Those ones, in my mind, are great candidates for it. I would probably, even though I don't use, I'm a robot surgeon for some cases. My partners do most of the isolated parastomals, and I think robotic offers a few advantages, and I'll just list them. Number one, the ability to very safely close the fascia, much easier robotically. Number two, I think we all know that getting up into the subcutaneous space to get all that bowel out, to free up adhesions, and to make sure that the stoma does not kink in the sub-Q. It can be very challenging to do open. It can be very challenging to do lap, and it sometimes requires you to actually take down the stoma and free it up and then reform the stoma. Robotically, getting instruments up and in and working in a very small working space is clearly an advantage of a robotic parastomal repair. Additionally, you can suture the bowel to the abdominal wall. I showed you that in that original sugar baker drawing, sewing the bowel out laterally. The last thing that's helpful, robotically versus lap for sure, is doing the operation at a very reduced insufflation pressure. When the pressure is high, your ability to lateralize the bowel is not as good as when the pressure is low. And they're going to be at zero when you leave the operating room. And so while we'll do a lot of the work at a high pressure, when it's time for mesh configuration, we're going to drop that pressure down to 8 or 5 if we can get away with it, because you can suture and work at a very reduced pressure, and that allows you to maximize the amount of overlap you get and have the mesh much more closely look like what it's going to look like when you're leaving the operating room.
Great.
Sir,
I think those. Yes.
There is one question by Dr. Sumit. He's unable to come on the mic. He's asking.
Did you guys do this? Did you guys do this on purpose? We know that Sumit likes to ask a lot of questions. Did you guys intentionally cut his internet feed?
No.
You got it. You got it, Eric. You got the entire drill. That's how we can. That's how we can shut him up.
Would or when would you still do a lap sugar baker with IPOM technique?
Yeah, again, I think that's similar to Sarfaraz's question. Yeah. The short answer is yes, we do. My group does them. Those ones get triaged to a few of my partners who are more lap robot surgeons. I get people who have already maybe failed that or who have a lot of other stuff going on and need something more complex.
There is one question from the audience. Dr. Shubham is asking, what are the indications for resetting of the stoma? Actually, I also wanted to ask you, in your series that you have shown 58 cases, almost 1/3 of the cases you have relocated the stoma site. So what were the indications for these relocations? Otherwise, in the literature, they discourage for the relocation of the stomas.
Yeah, so stoma relocation, stoma takedown and stoma relocation have a couple reasons to do it. The first is whether the stoma is in a site that the patient can manage. Okay, many people do not want you to move it because they're happy with where it is located, and so sometimes you might look at the CAT scan and say, "Yeah, this should probably be moved. It kind of misses the rectus muscle." But the patient likes where it's located, okay? And so, I try to leave them where they are. One of the advantages of a retromuscular sugar baker is you can get mesh overlap without resiting it. And so it's part of why I do that. Some people, it just needs to be resited or redone. The mesentery is too short to do the thing you're trying to do. It's in a bad location for the patient. The patients have horrific skin problems that are not going to be fixed unless you physically redo the stoma, and redoing it at that spot is not in the cards. So, I mean, there are a variety of reasons, but I will say that for the most part, we try very hard not to recite them. I will also just briefly say that if you look at that JAMA paper from the Cleveland Clinic group that I mentioned earlier, that just came out, even in the retromuscular sugar baker group, they relocated a large amount of stomas. It was more than a third of them were reformed or resited by taking it down. And I have to admit that I struggle to understand why they would do that. Like I actually don't understand why they would do that, because the whole point of the struggle of doing a retromuscular sugar baker is to leave the thing alone and not have to deal with skin breakdown and dead stomas and a bunch of other stuff. And so my experience with doing it is very different than what that paper suggests, which is that a lot of times you need to move it. If you think that taking it down and doing a keyhole repair is challenging, where the posterior sheath, the mesh, the bowel are all independent, I promise you that taking it down and trying to sugar baker it through and not make it too tight or too loose and get the overlap, I promise you that's a lot harder, a lot harder.
So may I extend that question a little bit, Eric? If you were to relocate, and would you then reinforce the area that with the mesh which has now been taken out? I mean, if you had a left ileostomy and took it to the right side, for example, or vice versa, would you put in a mesh on both sides, so which means a bilateral TAR in this patient?
For the most part, yes. Okay. One of the questions that I would stop and ask myself is, is there other stuff happening? Okay. If it's a heavily contaminated case and I'm relocating the mesh, and I say to myself, boy, I'm not really comfortable doing a retromuscular repair today, it's possible that I might just do nothing, with an understanding that this person is 100% going to get midline hernias, old stomosite hernias, a new parastomal hernia back, but that I haven't burned any bridges for a more complex repair in the future. Okay. And one of the challenges of parastomal repairs in general is that, I think plastic surgeons are very good at this. They're always thinking about the next step, and they think about staged reconstructions of things. As hernia surgeons, I think we're less good at that. I mean, as general surgeons, we're less good. Most of what we do is we're going to go in and fix the problem and we're going to be done. And this is one of those cases where you have to think a couple steps down the road. But the short answer is, if I'm moving it to a new spot and my intent is we're doing a permanent repair today, yes, I would do something to reinforce that spot with mesh. I would try and sugar baker it as best I could. If it's clearly not in the cards because the mesentery is too short, then I would do a little cruciate and I would deliver it through the cruciate. Okay. But again, if you do that, you have to think about, okay, well, what are my options when they recur? And those options would be to do a local repair with suture, to do an onlay repair with either a cruciate or a keyhole or something in the onlay space, or to go back intraperitoneal. I mean, theoretically, you could go back intraperitoneal, and do some form of an operation. What's limiting you in terms of your operative approach there is not that there's already mesh in the retromuscular space. It's that you already understand that this bowel can't be sugar bakered because the mesentery is too short. So any other repair that you're going to do is going to have to take that into consideration. It's going to be a keyhole or a cruciate or a funnel configuration mesh in the future.
Okay.
Actually, time is getting up. Shall we have a quick last question? This is by Dr. again Sumit. He's asking whether the presence or absence of a midline hernia, and I will also add any other hernia for that matter, will change your strategy.
Yeah, if there's a large midline hernia, obviously, I mean, again, you guys don't have as much access to the robot as I do, but even with robot access, most of those are probably more straightforward to do with an open approach. If they have smaller midline components in a parastomal, those for me would be a double dock robotar with a retromuscular sugar baker of the mesh. When there is very minimal or no midline component, you could either do that as an intraperitoneal sugar baker, or we do a lot of those now as a robotic retromuscular operation. If there's a very small midline component, when you start your flap, rather than starting at the edge of the rectus, you simply start on the contralateral side of the stoma as a pre-peritoneal surgery. You could theoretically do it like a tar up as well. You could theoretically do that as an ETEP approach and cover the midline. I mean, there's a number of options to do it. I don't do a lot of these as ETEP. The primary reason, I just want to say this, the Achilles heel of an ETEP is when there is bowel incarcerated in a hernia, and as you are approaching and doing your midline crossover, you accidentally injure the bowel that's in the hernia, okay? Every parastomal hernia repair has bowel that is incarcerated in it. It is the stoma loop, and you don't know where that's going to be located. And so as you approach that hernia, as you're opening the hernia sac to do your work around the hernia and the stoma site, you just have to be exceptionally careful that you do not injure the bowel. And when I do them ETEP, or when one of my partners is going to do them ETEP, the first thing we do is look at the CT scan and ask ourselves, where is the stoma bowel in relation to the hernia? Because we know the stoma is going to be stuck there, and so we try to find the spot where there may be some free space to open that sac and safely get across.
Thank you, sir. It was a very lovely and a very interesting subject, and you have explained very well. On behalf of Hernia Society of India and all my co-chairpersons, Dr. Deepraj Bhandarkar, Sarfaraj, Sumit Shah, and all the audience they are listening, I profusely thank you for sparing your valuable time and guiding us on this subject. Actually, when we are talking with Eric on hernia, why only parastomal, but any hernia for that matter, the time just flies. We never understand that how much time we have spent with him. And it was really a very fruitful discussion, and all of us have really enjoyed it. I request Dr. Sarfaraj to say a few words.
Yeah, I think I cannot fill in for Sumit Shah's shoes because he's a much better speaker than I am. But I'll try to do my best. Eric, what can I say? It's always wonderful to listen to you, and it's an honor and a privilege to be to have you over at Hernia Society of India. And there are so many people who are thanking us for this wonderful talk. It's from all over India. I can see these messages coming through, and I'll pass it on them to you. And this is a great topic to discuss, very difficult and challenging. And you bring in so much of perspective and experience. And for that, we thank you. And we hope that we can always go back to you again for your guidance on these topics.
Appreciate it. Thanks for the invitation.
Thank you, Eric. Thank you for everything.
Sumit is here. Finally, you got your voice, Sumit.
Yes. I was at the beginning and at the end. They did something to my audio in between.
Eric knows it why we did it.
Yeah. Okay. Bye. Thank you.
Thank you.